Thank you for joining us. Today we have our faculty development residents presenting. We have Sarah McCall from Scott Air Force Base, Andre Jones, Naval Hospital, Jacksonville, Dr. Jill Coster from Fort Belvoir, and Dr. Neff from Travis Air Force Base. And they're going to present each for 15 minutes, so we're going to get started. If you have questions, you can ask at the end of each presentation while they transition. So we have about a minute or so for questions. Please complete session evaluations either on the session evaluation form that I send, or we have a QR code that we can share with you that you can also complete the evaluation that way. Thank you.
All right. Good afternoon, everyone. Thank you all so much for being here, spending a little bit of time with me this afternoon. Again, my name is Andre Jones, third-year resident at NAS Jacksonville. Today, I'm going to be talking about the spiritual assessment. It was an idea that was brought to me by Dr. Kuckel, who some of you may be familiar with. We were just on the inpatient rounds together. And I don't know what it was in regard to me and him doing the patient-centered rounds, but it was a topic where he said, hey, this is something that's actually needed, and it's actually something that they're trying to push per the AAMC, which I'll reiterate here in a few. And we just tackled it. It took us about a year to complete. We recently had an article that was published in the AAFP in the October edition. So it's nice to kind of talk and spill a little bit from that recent discussion, okay? Of course, disclosures. Everything that'll be talked about, discussed, all of the information provided, I received no financial incentives in order to do so or be here, okay? All right, overview. Brief topic of what I want to accomplish and what I want you to grasp. We'll be defining spirituality. I'll talk about a scope of it. We'll talk about a few clinical situations that I feel like it was appropriate. The two tools that we use to conduct the actual spiritual assessment and a care plan, and then also discuss potential benefits and limitations in regard to this spiritual assessment, okay? So, in general, spirituality, more times than not, is typically defined as, hey, something that's giving you meaning, something that's giving you connectiveness. Religion is more so seen as kind of the belief and a practice, something that you do in a ritualistic manner. The biopsychosocial spiritual model is the one that's more widely accepted from the AAMC and from the Joint Commission. And the typical approach of what they like to do with this is they try to grasp a patient's physical, psychological, social, and spiritual aspects and see how you can interact all of those things together in order to provide good patient care and well-being. So that's the definition of that, okay? So here is a Gallup poll. When we initially did the presentation, this was the last time they had updated. It was actually in 2017. And prior to presenting the presentation for you all today, I saw that they released a new Gallup poll here in 2022. At that time, when we were initially doing it, they said, hey, and the way they do the poll in general is they'll get about 1,000 participants, and they just call people randomly throughout the 50 states and say, hey, very general, basic question, do you believe in God? They do not specify anything else past that. And it's either yes or no question. Obviously, in 2017, you could see that their results gave about 87% saying, hey, we believe in God. That was just a general question. But obviously, with the 2022 Gallup study, it's actually decreased, where now it's 81%. So looking at that, there's not a lot of evidence behind it, but I would presume that a lot of this, the new data they have is probably secondary to the pandemic and taking place and some of the people that may or may not have been involved with those who they polled, okay? Now, getting here with the scope of it, right? So when we initially approached this topic, we wanted to say, hey, now we had 87% of people who said, hey, I believe in something, right? And we wanted to know, okay, well, is that discussion taking place, right? Is there a gap between you saying that you have a belief and the AAMC and Joint Commission saying, hey, this is something that we should be discussing? Is it actually taking place? So in the first study, they actually had 4 family medicine residencies, and all they did was poll participants or the patients that were waiting in the waiting room, and they would bring a general questionnaire and said, "Hey, is this something that you would kind of want to discuss?" What they found was that about 70% of them in general wanted to discuss it, and they wanted to discuss it in regard to the topics here, right? Some of them have a loss of a loved one. They felt they could talk in regard to spiritual awareness in regard to a serious medical condition or a life-threatening illness. So we said, hey, why do you think it's important to even discuss it in regard to these topics? And they say, hey, I think that these discussions would take place and help me to make further medical decisions as far as receiving advice and taking part in the treatment that you guys feel is needed. And in another study, which was done in Colorado, they took an urban area and they were able to poll about 150 people and just said, hey, what do you feel, as in, do you feel like spiritual assessment is something that needs to take place? 90% of them said that they actually believed as well. And in that, they also stated, I have never had a discussion at all with any of my providers in regard to spiritual assessment. And 97% of them in actuality said that they hadn't received or heard anything in the past year as far as the spiritual assessment, okay? Now, that was from the patient perspective. The next thought was saying, okay, well, what about the provider perspective? What is going on from there? We found a study in Scotland, and in this one, it was a general practitioner, and all he did was just poll. He polled about 20 of his fellow general practitioners and just asked them about their attitude, their thoughts in regard to doing the spiritual assessment. And they kind of broke it down into 4 categories that you see here. The first category was those who just chose not to explore. All right, they were labeled as saying, hey, this is something that I kind of just reject. I don't think it's necessarily needed. I don't see how it can be applicable, et cetera, et cetera. The second one, second study was saying, hey, every once in a while I can kind of use this, okay? I can use a spiritual assessment and just kind of send them to a faith-based leader or somebody else, send a referral. The third group were listed as pragmatics, and we're just saying, hey, if the patient feels that it's necessary and the patient wants to do it, I don't see an issue with it, so we'll just do it. All right. And then you had the fourth group. The fourth group were those that were just saying, hey, I'm fully bought in, I'm actively engaged. I don't even feel the need to refer them out. I want to take part in everything that's possible in regard to the spiritual assessment. Okay. So the big part of this one was more so to understand the perspective, okay, from some of the general practitioners from that study, okay? Now here, in that same study, they asked them and said, all right, if you haven't been partaking or doing the spiritual assessment, what are some of the barriers that was taking place? A lot of them would, as if to say, hey, there's a lack of time, which is very fair. Training, right, because it's not something that's constantly or reiterated all of the time, which is also fair, along with the experience. And then they also had a certain uncertainty with initiating the discussion because they felt that it might rub the patients the wrong way, which is very understood as well. Also, there was a quality improvement project. This one wasn't done in a family medicine setting. It was the study was done more in a palliative care setting, which you'll probably see spiritual models more so utilized. But in this study, they said, hey, how can we actually implement doing the assessment more? What they did was they found if you take a team-based approach, they introduced chaplains while also educating the practitioners more about the spiritual assessments. They saw an increase, obviously, with the number of spiritual assessments that were completed from 49% to 72%, okay? So moving forward, in general, with all of the polls, there was probably about 5 situations in which the spiritual assessment seemed like it was most appropriate. A lot of them are in a hospital setting, especially in an inpatient setting, those who have, new news that are obviously breaking in that sense. 40% of the elderly in a hospital setting said, hey, I actually like to use spirituality, my means, the way that I think, the way that I process it in regard to my patient care and in regard to my thought process with the medical treatment and advice that I want to receive. Obviously, critical illness, substance use disorder, in a palliative care setting again, okay? Other clinical situations that we felt would be appropriate was with the discussion of the advance directive. So it'll be spoken about a little bit more here later. But with doing that, when discussing end-of-life care, I felt that was a perfect opportunity to not necessarily conduct it all the time, but at least open it up and say, hey, is this something else that you would like to discuss when planning out your advance directive? And then in one study, we found chronic disease progression. So what the study tried to incorporate was they tried to take patients when they first found out the diagnosis or a new diagnosis of something that was going to be chronic, and they slowly reiterated, hey, is this something that you want to discuss? If they did or did not, and track that along the way. And what they found was that obviously with the progression of the chronic diseases, by the end of it, more of them wanted to have that discussion. Okay, so we felt that was appropriate at that time. Okay. Now here, when actually conducting the spiritual assessment, there's two tools that we typically utilize. One is called the open invite, and that's typically has the benefit of just kind of broaching the topic, saying, hey, this is just something that we want to talk about. And if you want to talk about it, let's have a further discussion. The hope mnemonic is more so a kind of preset questionnaire that goes around just like, hey, what are your general thoughts of hope? Where does your beliefs, what is your desires kind of based from? Okay, and I'll show those here in a second. So the open invite, as you can see here, the first question here, just may I ask about your faith background, what helps you through hard times? So it's very general. So it's very general in that sense where it's just saying, hey, is this something that you'll be open to discuss for? Right? If they say, okay, you can move forward and you can ask further questions like, do you feel that your spiritual health is affecting your physical health? Does your spirituality impact the health decisions that you make? Something around that ballpark is the general consensus of the open invite, okay? In the hope, right? So the acronym, as you see here, you have sources of hope for H, organized religion, personal spirituality and practice, and the effects on medical care and end-of-life issues. So as you see here, the sample questions in general will relate similar to the open invite, but it's just more in an organized setting there, okay? So care plan with spiritual needs. The whole discussion of all of this, right, is so that we can understand and take the patient's perspective on their thought process with spirituality and be able to affect their care. And obviously for us, as far as the discussions of what we need, whether it's having the assessment, having it completed, and whether we need to refer them out, having it on file and being able to reiterate that with any further plans, healthcare plans or decision makings that need to take place. And then it also allows us to kind of have that thought process and be able to tackle, okay, is this something that I want to continuously grapple with or wrap my my thoughts with, right? Because it's also a challenge and a barrier that we'll have here on our next topic of, hey, not all of us will be well versed, right? Some of the barriers that we discussed earlier. So not all of us will be comfortable having this discussion or even opening it up, right? So knowing our resources and avenues to go in that ballpark will be very helpful. Some of the interventions that I found was interesting here, right, is we talked about, mindful-based intervention, imagination, meditation, and prayer. So this is secondary in the sense of after the spiritual assessment, and if they want to have that discussion, right, because we're not going to be doing any of these, right, probably in our clinical setting, whether it be the outpatient setting, and very rarely will we'll probably be doing any of the interventions in the inpatient setting. But to know, again, right, whether it's a handout, whether it's knowing the resources, knowing when to bring in a chaplain, whether it's in the outpatient or inpatient setting, and having those discussions to further help them. A few of the studies and the evidence that we had, right, was after these interventions had taken place, you see, right, a lot of them had more times than not a decrease, right, in the evidence of depression, anxiety, and overall just had an improved quality of life. Okay, and as always, please, we'll continue to respect the right of the patients if they choose and they say, hey, this isn't something that I want to discuss. So overview of what we discussed. We went over the definitions. We talked about the scope, also identified appropriate clinical settings. We went over the tools that's needed to even conduct the spiritual assessments. And we talked about a different care plan with the patient's spiritual needs in mind. Okay. Thank you. I will open it up if there's any questions at this time. Thank you guys so much.
All right. Hi, everyone. I'm Sarah McCall, and today I'm going to be talking about relative energy deficiency in sport, or RED-S for short. I'll be honest, the reason why I chose this topic is a little bit more personal for me. I had a college teammate that I played basketball with, fifth-year senior, who believe it was my junior year, had several months with amenorrhea, went to the doctor out of concern, and the doctor had told her, oh, that's normal, your period will return once you stop playing basketball. She spent that year battling several injuries, and looking back now, for what I know about this, what I've learned over the years, I wonder if her last year playing could have been different. So my goal is to educate us all here today on what relative energy deficiency in sport is, apply the signs and symptoms of those to a couple patient examples, and then recognize the initial treatment and management of RED-S. Obviously, this is a pretty in-depth topic, so I won't be going over the entire management and treatment course, just a little bit of an overview. So to start, I have a poll everywhere question, if you don't mind playing along. Just saying who all here has seen or diagnosed RED-S in your practice. Oh, should be working. Is it not going through? Did you text you texted the number? Did you text the number? Dang it. Well, it should be popping up. Yeah, that was my go-to. All right, so we got a small crowd here. So technical difficulties here. Anyone here believe they've seen it, diagnosed it? Okay, so one couple, not too many. All right. Honestly, that's not that uncommon. So they did a couple surveys over several different years where they polled several different providers on who knew what RED-S was and who knew how to treat it. And all of those surveys came out to be about 25 to 30% of the polled providers knew what RED-S was. Only about half of that number felt comfortable treating it. So not very commonly known, despite this terminology being around for several years now. RED-S is an expansion from the female athlete triad. So some of you may be familiar with that, with the amenorrhea, the bone health, and the energy deficiency, eating disorder associated with that. The studies over the years had shown that males were getting it and females were showing other symptoms as well, other than just that triad of symptoms. So RED-S is impaired physiologic function caused by relative energy deficiency. So that's energy intake is less than energy expended. And this is affecting, but not limited to, all of these here. So metabolic rate, menstrual function, bone health, immunity, protein synthesis, cardiovascular health, so affecting several different areas of the body. As you can see here, this goes over all of the different areas that we've noticed this to affect different patients with. So we have the female athlete triad in that top corner with the bone health, the menstrual function. But we have several other things that we've noticed as well. So we've noticed that these patients have decreased immune function. They're getting more upper respiratory infections and they're more at risk for other infections. They're having GI symptoms, decreased transit, constipation. They're at an increased risk for injury other than bone injury. They're having decreased endurance performance, decreased muscle performance. There's anxiety, there's depression associated with this. There's different hormonal functions. So we're seeing increased cortisol levels, decreased TSH. All of that is affecting these patients with low energy availability. So we've got patient case 1 here. We have a 35-year-old active duty male who works cybersecurity. He's 5'5", 180 pounds. Otherwise, he's healthy. He's an upcoming PT test and has failed twice. Started preparing about a month ago and has already lost 20 pounds. He's concerned about worsening anterior shin pain, fatigue, and what he describes as a cold he can't seem to shake. So just kind of shout it out. What sort of things are we seeing here that are making you a little bit concerned? Maybe I need to be concerned about red S here. Mm-hmm. Yeah, the shin pain, fatigue. All right. So that 20 pounds in 1 month, that shin pain, that fatigue, and that cold that's kind of been hanging around, all of those have are things that put your radar up a little bit more. Maybe I need to get a little bit more history on how much exercise this guy is doing, how much food intake he's doing, work him up, see if there's anything concerning for red S in that history. Okay. Patient case number 2, we have a 21-year-old otherwise healthy active duty female presenting in your hospital for readmission with recurrent infection and fatigue. So she underwent a open reduction internal fixation for treatment of a right fifth metatarsal stress fracture about 4 months ago. She subsequently developed osteomyelitis, required multiple surgeries. Prior to this, she had been training for a marathon, running up to 60 miles a week. Even after that initial injury of the stress fracture, she continued to run. Further history revealed she had restricted her diet to 1,800 calories per day, eating mostly chicken and rice. And you do some digging in her chart and notice that she's had a previous oligomenorrhea workup 3 years ago with her previous PCP. So again, what kind of symptoms are we seeing here that makes you concerned? Yeah, the whole thing really. So this is, while may seem like a very extreme case, this case actually presented on our inpatient service my intern year, ended up doing a case report on this young female. And I use this case as an example of how extreme this can go if we don't catch it earlier. So this was an active duty female, and she got that fifth metatarsal fracture. She ended up taking about a year to recover. So she was mobility restricted, duty restricted, fitness restricted for about a year while she was dealing with all of this because of the stress fracture and the subsequent infections and everything else that caused. So the first thing we need to do when we see these patients is assess their risk. So the IFC came out with the Red S CAT, the clinical assessment tool, to help us kind of gauge where these patients are. Our high-risk patients are the ones we're most concerned about. So that greater than 10% weight loss in 1 month, severe eating disorders, extreme weight loss techniques. If it's very extreme, they may be in the hospital. You may see some severe EKG abnormalities, some hemodynamic instability, and lab abnormalities as well. Moderate risk, substantial weight loss 5 to 10%. They're having some abnormal menstrual cycle, reduced bone mineral density, stress fractures, lack of progress in treatment. And then we have our low risk section, the healthy physique, the healthy diet, exercise habits. We're hoping to get all of our patients here eventually, right? So we're kind of gauging where they are throughout the process, where they start and where we're progressing them to. Managing this based off of what category they fall into is kind of where you're going with their treatment plan, as far as, are we stopping them completely? Are we pulling them out from activity? we're just keeping a close eye on them while they're participating to where we hope to get them in that full sport participation. Again, we're kind of reassessing throughout the treatment course, and they may be moving back and forth through these lights, so to speak. Our ultimate treatment goal is to correct energy availability. So we do that by decreasing the expenditure or increasing the intake or both. The studies have shown that you get to that low energy availability around 30 kilocalories per kilogram of fat-free mass. And to correct that, that energy balance is about 45 kilocalories per kilogram per fat-free mass. This comes out to about 250 to 350 calories per day, depending on the patient. So essentially an extra snack, a little bit extra at each meal can get them there. And we want to use a multidisciplinary team to help. So involving the dietitian, we're maybe sending them to get a further assessment to figure out exactly what their fat-free mass is and getting those calories calculated appropriately. Mental health, as appropriate, coaches or in leadership as well, especially for our active duty patients, and then others as appropriate depending on what sort of other symptoms they're having, whether that be psychiatry, GI, any other specialists, endocrine. So to summarize, so Red-S has evolved to include personnel of all demographics. It's not just that female athlete triad, and the symptoms have expanded beyond the female athlete triad as well. To include impairments in a variety of symptoms. And these symptoms can be pretty subtle, so they can be hard to recognize when we're catching them in that initial phase. Treatment is focused on restoring that balance using that multidisciplinary approach, and the management should include that clinical assessment to determine how much participation and return to play our patients should have. So my references. Any questions? Thank you. Yeah. Other questions? Okay. Thank you. All right. We can chat after. Did you just say this?
All right, so I'm the next one to go. I'm Jill Coster. I'm one of the residents at Fort Belvoir Community Hospital. I'm interested in geriatrics, so that's why I'm presenting on this. It's very different than what Sarah just presented, but basically it's about social isolation and loneliness in the older adult, especially from the pandemic. This has become a big issue. So objectives, basically, I just want to identify like some comorbidities that go along with social isolation and loneliness, differentiate between those two terms because oftentimes they're used interchangeably, and then talk about some different interventions that are available for us and patients. So like I mentioned, the pandemic definitely plays a role in all of these topics, but it's definitely gotten worse. So adults greater than 75 years old are expected to double in the next 20 years. The number of geriatricians are not going to be able to keep up with that growing population. So us as primary care doctors are going to be responsible for taking care of these patients as they age. In the US, which is similar to the stats that I saw in like Europe and Asia countries, 25% of older adults are socially isolated, and of those, 43% of them report feeling lonely. So that's a pretty significant number, and oftentimes it goes dismissed when they're at the doctor. The reason that we care so much is because it's associated with a lot of other comorbidities. Dementia, there's a 50% increased risk of developing when they're socially isolated or lonely. Another article said there was a 1.58 increased risk of dementia when they're social isolated or lonely. Coronary artery disease, stroke, repeat hospital admissions, longer hospital stays, not to mention a lot of the mental health aspects that go along with these topics. So definitely could be masked as one of these comorbidities. So the reason I have these pictures up here, alcohol use disorder, obesity, smoking, loneliness and social isolation actually either equal or surpass these when it comes to mortality and morbidity and mortality. So it's equivalent to having alcohol use disorder. It surpasses the risk of obesity, and then it's equivalent to smoking 15 cigarettes per day. So does anyone know the difference between social isolation and loneliness, or want to take a guess? Okay, I can also just go through it. All right, so social isolation is more like objective. So there's different screening tools out there, which I'm not really going to get into during this presentation because of the limited time. But if you look it up, there's like a UCLA one along with some others. And that's just the objective measure of their social status. Loneliness is really self-reported, so it's more of the subjective measure. And then I put the prevalence and mortality risk up there. The prevalence, the percentages are very broad, but the mortality risk, because of all the associated conditions of social isolation is 29%, and then loneliness is 26%. And then I didn't put it up there, but there's also social vulnerability, which is like how likely they are based on their social situation to develop one of these things. So when you have a patient coming into your office, you definitely don't have to do this for everybody, but if they're older and they have a lot of comorbidities, it might be useful, especially with the pandemic, to address or kind of gauge where they're at on this scale. So first thing to do is exploring what is their degree, and that's where you can use one of the screening tools or just like asking them, like, do you have a good social support system? Do you feel lonely? Then you want to determine if they are, what would they like to be different so that you have a focused goal and what they see their future like. And then action, what can be done, how can this be accomplished, what can you do, what can the patient do. So it's kind of like we do for any type of illness, but this is just how they recommend doing like this 3-step approach to address it. So I thought it was interesting. The US honestly didn't have a ton out there that were doing for it, but other countries did. So the Campaign to End Loneliness in the UK is like this network to help at national and local levels. Social prescribing they're doing in Canada. They started around like 2018, it looked like, and then it's progressed through the pandemic. And it's basically a way of providing resources to people. And then Better Later Life in New Zealand was another one out there. And then when I looked at US ones, there's some scattered, like either like hospital based or something, but there wasn't really a united front against this. So this is from the social prescribing in Ontario. They have like this whole website, which I put at the bottom. It's actually really interesting to read about what they're doing, but this picture kind of summarizes everything up. And then this is from the Better Later Life in New Zealand. They have like 5 key principles that they base everything off of. And they have like this whole booklet PDF online about like how they're doing everything. So I just thought it was really interesting. So ways that we can help, I know we as a country don't really do the best job compared to other ones addressing it, but social prescribing is something that we can easily incorporate into our practice, especially as residents in the geriatrics clinic or just being primary care doctor. You see a lot of geriatric patients, and especially in this area, there's a lot of veterans and retired military patients. So across multiple studies, they address different interventions, which I'll get to shortly. And there's kind of weak quality evidence, mostly due to small sample sizes and short follow-up times. So you really have to take a patient-centered, individualized approach, just like we do with everything else. But really, there's 2 broad topics. There's like group-based interventions and then individualized or one-on-one. So this is where I was going to do like a choose your own adventure thing. Does anything sound interesting to anybody? Animals? Yeah, okay, everybody picks that one. So you could probably guess it's more like support animal type of thing. So you can either do like group settings where you have a support animal calm or individual. And I thought it was very cool to read a study about robotic versus living dogs. Some of you might have heard of this before, but they did a study where they compared in older adults, like having a robotic dog with some people and then having a living dog. There was a higher attachment rate to the living dog, but in terms of reducing loneliness, it actually significantly did it for both groups. So not that we're going to be prescribing robotic dogs, but just something that I thought was cool. Anything else? Yeah. So befriending, it's really just like helping make new friends and like mostly volunteer based. So there's a lot of volunteer programs that kind of halted during the pandemic, but there was a lot of volunteer programs, especially at like assisted living, nursing facilities that would go and provide companionship. And then I was reading about something that was published in October of this year. I guess there's this undergraduate gerontology student who created this program, and they're starting to implement it other places where it's more like resident based in the nursing facilities. And they find out facts about all of their neighbors and they put it all in, and everybody comes together and they have to guess like who goes with which fact, and it's to try and make people that have friends with people that have similar interests as them. So something that a lot of the nursing facilities and assisted livings are doing. Anything else? So a lot of this is going to be like stress relief, mindfulness type activities. At a lot of the facilities, they do like group therapies. A lot of them have like yoga classes, which they're starting to implement again after the pandemic. So all of them are actually shown to be effective in the studies, at least the ones that I saw. So it's something easy that you can tell people to do if they're comfortable going out, you know, and they can wear a mask or however they feel comfortable. I wasn't sure how much time we had, so we might be able to do all of that. Oh, we have time. Okay, let's do 2 more, I guess. All right. So any like leisure activity, gardening, sports participations, all of those are different skill development type activities. Volunteering is even one, and the study showed that the ones that were productive compared to like passive activities. So passive would just be like listening to the radio or watching TV. So the productive ones where it was gardening, doing something active, those were found to be more effective. All right, one more. You can pick between, I guess, social facilitation and healthcare provision. All right, healthcare provision is kind of similar to the befriending, except it's more like healthcare and social worker oriented instead of volunteer based. But it's really just different organizations that can help support the older people. And then pretty much all the studies that I saw demonstrated effectiveness on this except for one. So, all right. So in summary, social isolation and loneliness is often overlooked, especially by the primary care doctor, because we see these patients so often and they have a lot of these comorbidities, but it is extremely common and it can have long-lasting effects on mortality and morbidity. So it's really important to use a patient-centered, individualized approach, kind of going through different interventions that might help that specific patient. These are my references. Any questions? Yes, ma'am. Mm-hmm. Yeah, I think it's definitely dependent on the practice. I know at Fort Belvoir, it is difficult unless we're the ones asking the question. And we've tried to implement other screening tools for other reasons, and it never really has been effective. But I think even just asking the question, are you feeling lonely, to patients that you might think that, you know, they have all these comorbidities and they're older, and just addressing it, instead of trying to like hand them a questionnaire and do all of that, unless you have a lot of time. But there are like 3-item loneliness scales. That's probably the shortest one that I saw. So if you're going to do one, I would suggest that one. Any other questions?
So I'm Catherine Neff. I'm a third-year family medicine resident at Dave Grant Medical Center for Travis Air Force Base. And today I'll be talking about obesity and pregnancy. We'll do a brief review on screening and treatment recommendations in primary care. So the objectives of this lecture, by the end of the lecture, a learner will be able to discuss health conditions that are at higher risk to develop for patients with obesity and pregnancy, identify screening recommendations according to AAFP and ACOG guidelines indicated in patients with obesity at our routine OB prenatal visits, and be able to educate pregnant patients on recommendations for diet and exercise in pregnancy, pulling from the guidelines of ACOG, AFP, and lifestyle medicine guidelines, which is a new program that we're implementing at our hospital. So in terms of obesity, the definition is the same for your non-pregnant population, but the importance is we do follow the pre-pregnancy weight and the pregnancy and BMI throughout. So the obesity is a BMI of 30 or greater and overweight 25 to 29. This is the most common medical condition in women of reproductive age. And why this is important is because there's a rising prevalence of obesity, not just in the pregnant population, but all populations. According to the National Health and Nutrition Survey in 2020, 33% of women 20 to 34 age are obese and 58.4% are overweight. So that's quite a large number and expected to be even larger now that we're post-pandemic with increased people who are sedentary and possibly have worse nutrition at home as well. And looking at the prior information from CDC in 2016 to 2019 shows higher rates of obesity in minority populations as well, looking at non-Hispanic Black, Hispanic, and non-Hispanic white, and in all populations that has increased as well. In the next slide, we'll see the infographic of the CDC in 2016 to 2019 showed not only are the rates of obesity higher, but it also correlates to worse outcomes in pregnancy as well. So, in addition to the health disparities in minorities with obesity, we're also concerned that pregnancy or obesity and pregnancy increases the risk for optimal ultrasound screenings for fetal anomalies, labor complications, depression, hypertension, preeclampsia, macrosomia, shoulder dystocia, and other risk factors as well. And here in this bottom infographic, you can see the rates of these complications are highest in the non-Hispanic Black population and also higher in the non-Hispanic American Indian as well, compared to the non-Hispanic white population. So looking at the AFP, obesity and pregnancy, it does show an increased risk of the macrosomia, shoulder dystocia, preeclampsia, and GDM with a rise of BMI. And not only the morbidity, it's also increased mortality with increased risks of fetal death, stillbirth, and infant death with the increase in the maternal BMI. So to kind of frame the importance of our screenings, now that we've talked about the prevalence, I have a patient case that we can talk about. This is a simulated patient talking about some of the risk factors that we were addressing before. So you have a new OB patient, Ellie, for your first appointment together. She's a 35-year-old G2P0010 at 12 weeks by LMP, consistent with dating ultrasound at 8 weeks. Your intake vitals, her blood pressure is slightly high at 140/90, heart rate 90, she's statting well, her BMI is elevated at 40. Physical exam, just note that she's gravid, pregnant. And in terms of her other past medical history, you discussed that she has a history of obesity and PCOS, but no surgeries. Her mother has a family history of type 2 diabetes, no allergens and no medications. And her social history is notable for tobacco use, a half pack per day, occasional marijuana, and a glass of wine per day, but states she stopped at conception. And her demographics, her father's African American and her mother is Asian American. So in terms of this patient, we'll talk about the importance of screening for GDM, antenatal testing, growth ultrasounds, and aspirin awakening in pregnancy. And in particular, these are the David Grant CPG guidelines developed by the Women's Health Clinic and FMOBs. And in the red is highlighting everything that Ellie would require for her screenings. Given that she is overweight, obese category. She had hypertension at multiple visits, PCOS, morbid obesity, family history of diabetes, ethnicity. All of these increased risk factors indicate indications for early screening of the 1-hour GTT at her new OB visit. And then screening, the first recommendation we're talking about early screening for gestational diabetes in the obese pregnant patient. We would do the early 1-hour GTT for the GDM screening, with the positives being the 1-hour GTT greater than 135 or diagnostic if it was greater than 200. And then you would further lead to the 3-hour GTT as well. However, there's certain indications where you would not do the glucose tolerance test and instead you do a 2-week blood pressure or blood sugar check, such as if you had a patient who had a history of gastric bypass, or if your patient refuses to do the glucose tolerance test as well. The other important screening in this patient population would be considered the increased risk for hypertension and preeclampsia. With that, you'd also be screening the blood pressure at every visit, but in certain risk factors, you'd also consider low-dose aspirin use in pregnancy if additional risk factors. And I've included this ACOG chart here for consider low-dose aspirin if the patient has more than one of these moderate risk factors. And it was a grade B recommendation with USPSTF. And with that, you'd do the low-dose aspirin, 81 milligrams, starting at 12 weeks and continue until delivery. But you wouldn't start after 28 weeks. And it is important to note the patient should be taking this about 90% of the time to be efficacious as well. In addition, we have to consider what about ATUs and more tests. According to our guidelines, if pre-pregnancy BMI is greater than 40, then you would start at 36 weeks doing the NSTs and STP, single deepest pocket, once a week, and then consider to referral at HIROB. Different MTFs may have different guidelines if they would like to deliver on base. Our current recommendations, if the BMI is greater than 45, then we refer off post for delivery for these patients. Another consideration, given the body habitus and certain obesity or patients with obesity, you may not be able to get a good fundal height. If you're not able to adequately assess the fundal height, then you consider growth scans as formal ultrasounds starting at 28 weeks and doing that every 4 weeks to assess. So in this patient, given the screenings that we discussed were important, how do we get Ellie and her baby to a safer delivery? With the mainstay of this, we want to talk about healthy diet and exercise in this patient and encourage her to continue or to start an exercise program in her pregnancy. They looked at certain risk factors that could reduce obesity-related complications in pregnancy. Specifically, they looked at exercise, decreasing the risk of cesarean delivery, operative delivery, and exercise in the year before pregnancy, decreasing the risk of gestational diabetes. So for her, we'd be tracking her weight throughout her pregnancies at her routine OB visits, and would be following for her recommended weight gain during pregnancy. For obesity with a BMI greater than 30, it would be recommended 11 to 20 pounds that we're monitoring during her pregnancy, 25 to 29, the overweight category 15 to 25, and normal weight 25 to 35 pounds. In terms of programs that we've implemented at our hospital, we have a lifestyle medicine patient education course, which meets for a 1-hour class in 3 to 4 sessions per month. So it's just a patient commitment of 3 or 4 classes to learn about lifestyle medicine. We have a class on nutrition, a class on exercise, one on stress management and sleep, and one on reducing risky behaviors. There, furthermore, is like another class you can take through the Lifestyle Medicine Association on pregnancy for learning about that as well. But the healthy diet and exercise are the same recommendations, whether you're going to ACOG, AFP, or the lifestyle medicine recommendations. And it can also be multidisciplinary with your primary care, doctor, OB, dietitian, or behavioral health counselor, depending on which is the appropriate for the patient. A common question you may get asked, am I eating for 2? I think patients ask this less now that there's more information out there and people seek information on the internet. But patients should be counseled that pregnancy does not require doubling caloric intake, especially since many patients are already eating over the daily recommended caloric intake. So one of the nutritions, this is taken from the lifestyle medicine recommendations, is the safe recommendations is 350 to 450 calories per day above the previous intake or the recommended caloric intake for that patient. And they include examples of healthy snacks, such as bread with avocado, Greek yogurt, or a cup of blueberries. And we have a cookbook that you can take or give to your patients in our clinic as well that kind of gives good specific examples. Specifically, the low glycemic index and the Mediterranean are good examples. Personally, I really like the Mediterranean diet. Referral and counseling, you can offer them the one-on-one nutritional counseling as well, because that can be good for longitudinal follow-up with a patient. And the lifestyle medicine also showed improvement with maintaining euglycemia and avoiding glycemic spikes with walking 10 to 15 minutes after each meal. So for your patient who doesn't exercise a lot, that may be a simple way to kind of start including their exercise regimen is just a little bit of a walk after each meal for 10 to 15 minutes. But the focus is a collaborative effort and importance of like patient education. This is the infographic, some of the handouts we have for these patients. You can talk about different food categories and recommendations for them. And then for their exercise goals, 30 minutes of moderate exercise for 5 days a week or 150 minutes a week. For someone who may not have been exercising, it might not be a good time to start engaging in a lot more exercise, just as we heard about the VRED previously. It's all about slow, sustainable changes. With recommendations to avoid the unsafe activities, particularly according to like the ACOG, and this is AFP 2020 article, such as contact sports, scuba diving, skydiving, that type of thing. But lower activity things might be recommended, such as walking, prenatal yoga, running, stationary bicycle. So definitely about setting expectations, because for a patient who isn't engaged in regular activity, a lot of this can seem super intimidating. So just proposing small, sustainable changes that they can incorporate in them. This is also in the 2020 article about pregnancy myths and practical tips about not placing patients, even those at high risk, on activity restrictions to prevent preterm birth, and do not recommend routinely activity restriction during pregnancy. And then in addition to the nutrition and exercise, don't forget the prenatal vitamins. And these are the recommended micronutrients during pregnancy. And I include this especially for the interns or people who haven't been pregnant, where they're super nauseous. You might want the pills that are really big. So these are the gummies, but then consider about how much sugar and how many calories are in the gummies as well. We reviewed the screening recommendations, lifestyle medicine approach, and AFP and ACOG guidelines. Does anyone have any questions? I think I can find that. I think the lifestyle medicine sent it to our clinic, and then we have like a stack of them. So I can ask, I think Dr. Gowrie is our POC for our clinic, so I can ask where we got that specifically. That one is particularly plant-based. So here we talked about low glycemic diets, Mediterranean diets, and then lifestyle medicine certification. They're very focused on the plant-based, which doesn't mean you can't have meats. It just has a lower amount of meat and focus in your diet. Yes, sir.
I think when you first came in for your first visit, and they had that.
I would look at the last trends of their hemoglobin A1C as well, if I have that relevant, and then see if that is more the type 2 diabetes or gestational.